Hello. Yeah, I'm Dr. Dipa from Kolkata. It's a great pleasure to be a part of this program. Now, in working hand in hand, my topic is managing the sinking plate. The term sinking plate reminds us the tragic story of Titanic. But in my case, anyhow, I was able to save my case of Titanic. It's a 38 years old myopic female with a soft PPC. The IOL power was 16 diopter. Usually, I prefer to do clear corneal phaco, but here, from the history, it suggests that there is a high chance of PCR. So that's why I did this limbal tunnel and continued my phaco. After doing this, I started the RHEXIS. The RHEXIS was of adequate size. It was complete. Then I did the side port and main port. As we all know that hydrodissection is contraindicated, so I tried to do the mechanical dissection. It will separate the capsule, entire capsule from the cortex. Then I tried to do in-out hydrodissection or delineation. I don't know how much successful I was there. And then I did a central trench with a very low infusion rate. Now here the cataract was very soft, so I manipulate the lens matter, then I try to aspirate them and tried this step repeatedly. And whatever the nuclear matter was there, I tried to separate those in a piecemeal fashion. Now, while doing so, I just noticed this part of the nucleus was very sticky, it was very difficult, and I was guessing something would be wrong there. And after some time, I noticed there is a break in the posterior capsule. And there is a PCR. So immediately I put the viscoelastic, try to stabilize my vitreous phase, and then I thought I could remove this part with the phaco probe in a epinuclear mode, but this was my great mistake. As I tried to do this, some of the cortex I could remove, but my PCR increased, though the parameters was very low. Then I thought I could take the help of the Simcoe, but this part was very sticky. Then I tried intravitrectomy and tried to remove the cortex, but while doing so, a few chunks of cortex went down, but most of the part I was able to remove. And then I put the PCRL in the sulcus and completed my case. The patient came on the second post-operative day. The vision was quite good. It was 6/9, and there was no reaction in the anterior chamber or in the vitreous phase. I explained this to the patient and asked her to keep follow-up every 15 days and added the oral steroid. So my take-home message is, though I followed all the cautious steps for this posterior polar cataract, but a single mistake changed the course of the pathway of my surgery. So one thing is very important. If there is a PCR, no such procedure should be done that risking the extension of the tear. So thank you all. Thank you
Yeah,
for your
thank you, Deepa.
patience.
And just before we go on to the next speaker, please, Dr. Sangeeta, you can come over as we go on in this discussion. Dr. Shilpa, was she correct in the way she withdrew her probe after noticing that PCR, one thing, and could we have used a tricot? And another word from Dr. Priya before we sum up this case.
Yeah,
Just Dr. Shilpa,
that's exactly.
please
First
put
of all, congratulations. You managed it wonderfully. Uh, what I would do differently is you said that you felt something was wrong. The pieces were not coming properly into the probe. That is when you realize that there could be a PC rent. So, very important not to just come out, wait there, bring down your bottle height, reduce your parameters, inject an OVD, and then make sure that the anterior chamber is properly formed and then come out. Because then, even if you have a rent, it will stay there, it will not extend. That is one thing. And secondly, I think when we should realize that there are different types of posterior polar cataracts. So when you see pre-operatively that there are radial folds coming towards that PC, the polar cataract, that means that you need a VR backup.
Correct.
But when you see that there are no such folds, you can probably say, I don't need the help of the VR.
Thank you, ma'am. And Dr. Priya, quick
I
word,
will
Dr.
add
Priya.
one quick thing. The biggest mistake, everything is fine, we all make mistakes, but the biggest mistake is when you are having a PCR, you should not enter the eye with the phaco probe. That's the biggest thing. The surgery should have halted at that point. You take a Tano suture, close down the corneal incision, make a pars plana incision, go through that, do a not a posterior but a pupillary vitrectomy. I'm not saying to do anything extra, but you need to clear out all the vitreous which is pushing up from behind. Now, because when you go from the pars plana side, you are shaving off all the vitreous which is there in the pupillary plane. If you do the same thing from your corneal wound, you will be cutting down a vitreous, but you will be still having some amount coming up. So you need to first block that. Having blocked that, if you know that you have a good amount of RHEXIS, you just inject the intraocular lens. Whatever lens matter remains on the top can be removed with the vitrectomy probe and with the phaco probe. So it can be easily managed. But when you have a big PCR going in with a phaco probe, thinking that you can pick up that nuclear material, it's only going to enlarge. And
Thank